Good evening, and thank you for joining me. I'm Joe Carbonetta, and this is Arroyo Live. Our program has moved to its new night and time, now on Thursday nights at 5 p.m. on this station. Produced by and through the facilities of Pasadena Media, the purpose of this program is to help enrich our community through informative and meaningful conversation. Remember, you can share your questions or comments with us anytime at arroyolive@pasadenamedia.org. A year into a global pandemic, the COVID-19 virus continues to spread at an alarming rate. Closures and lockdowns, ranging from limited to complete, seem to have become the new normal. The medical community has, at times, struggled between being overburdened and being overwhelmed. And reaction from the public has ranged from fear to cautious optimism and from apathy to incredulity. Despite the anxiety and uncertainty, progress continues to be made. 2 vaccines already being administered are showing signs of helping to contain the spread. And even more vaccines, some only awaiting final approval, may soon be on their way. This evening, a day after the historic inauguration of our nation's 46th president, President Joseph Biden, we take another look at the COVID-19 virus and our progress as we continue to fight our way through it. I'll be speaking with several doctors from City of Hope, designated a comprehensive cancer center by the National Cancer Institute and a national leader in medical research and treatment. Stay with us. This is Arroyo Live. Joining me now is Dr. Sanjit Dadwal, Chief of Infectious Diseases at City of Hope. Dr. Dadwal, thank you for joining us. How are you today?
I'm doing wonderful. Good morning, Joe, and thank you for having me on the show.
Certainly a pleasure to have you here. Dr. Dadwal, let's get right into it. What is the current status of the pandemic, both globally and nationally?
Well, I'd say the pandemic, which has been with us since early last year, has been quite, how would I say, quite an experience. I'm saying the global cases are almost at 96,433,000 based upon John Hopkins website. Within the United States, we are at 24 million cases now. And as you know, within the Los Angeles County, also we continue to see the rates go up. And as of today, we have surpassed 1 million cases within the state of California. And there's, as you know, significant mortality which is being associated, as you've seen on LA County or national levels as well as CDC, the number of deaths we were anticipated to touch close to 500,000 by February or end of February.
Speaking of the death rate, some statistics that are floating around right now suggest that more Americans are being killed by this pandemic than in all of World War II. Does that surprise you?
Well, I'm saying it doesn't surprise me given the numbers you see. I'm saying, in fact, it's already been stated that since the beginning of this year, you've seen more deaths due to COVID-19 compared to many other diseases, cardiovascular diseases, cancers, accidents, and whatnot. So it is very sobering. It is not surprising knowing what we know.
Well, we've also learned, and we are constantly hearing new reports of new strains of the virus being discovered, the most recent of which is being characterized as a stronger variant, more infectious, not necessarily more deadly, but more infectious than the original strain of the virus. Can you tell us a little bit about that?
Yeah. So there's more than one strain which is circulating, and we have identified one of the strains, the UK strain, within the United States. In fact, LA County recently reported having identified that here too. They have different mutations. There's a UK strain, there's a South African strain, and there's also a Brazilian strain. And the mutation is a change in the virus, which is more of an evolutionary thing for the virus. We see that happen in influenza. It is not surprising that we're seeing it in coronavirus, but it is concerning, even though it is not causing excess deaths. But the concern here is that it is more transmissible. So if it is more transmissible, it can infect more people within our population. And then when you have the vulnerable population, that's where the risk for death is. So the most important thing is getting vaccinated quickly and also reduce transmissibility by still practicing all of the things we've been saying since the start of pandemic. Wash your hands, cover your face, things of that sort, and maintaining social distance.
Well, Dr. Dadwal, you mentioned that it's not surprising that we are seeing new strains of the virus, and you did liken it to the flu. But my question is this virus mutating about the same rate as a flu, or is this virus mutating at a faster rate? It seems that every day we're hearing about a new strain being discovered. Is that normal?
Well, so this is a new virus, so it's not even normal to have pandemic. This is an event which is happening after a century. The last one was 1918 Spanish flu, so there's a lot to learn here. And I do not know if we had the technologies back then to sequence the viruses in real time. But yes, it is surprising because, as you know, flu is a seasonal thing, and there's a minor shift. Here we are seeing all these mutations, which is concerning.
Okay. What about vaccines and the current status of the vaccines and the vaccine rollout? Again, going to major reports in the media, there was originally reports that there was quite a bit of vaccine available, but the rollout was unprepared. Now we're finding out that there may not even be as much vaccine as we were originally told, and there are questions about whether there'll be enough for everyone to get a second dose for those vaccines that require 2 doses. Can you talk to us a little bit about the status of the vaccination process and the progress on vaccines? We know that there's actually 1 or 2 more scheduled to roll out, hopefully in the next month.
Yeah. So Joe, this whole thing about vaccination, as you know, has been quite chaotic. Uh, the, the states have been left to develop their rules based upon CDC guidance as well as ACIP guidance. However, it's difficult to state as to what goes on at the level of the state and local counties and the communication within them. I'm not privy to those, but yes, you're right. So there's definitely concern that the vaccine is still sitting on the shelves and is not coming out to patients or to their arms, as people have been mentioning. That's a real challenge, but I see there's a glimmer of hope with Los Angeles County having huge mega sites where they're planning to vaccinate individuals who are in their phase 1A and then moving on to phase 1B vaccination, a tier system which they have developed based upon vulnerable populations.
Well, Johnson & Johnson is one of the manufacturers that is hoping to get a vaccine into general circulation in the coming month. Theirs is a vaccine which evidently will only require a single dose, as opposed to vaccines like the currently in use Moderna vaccine that requires I guess what amounts to a booster shot roughly 1 month afterward. Certainly there will be advantages to the single shot approach. There have also been suggestions that the Johnson & Johnson vaccine will in fact have an even slightly higher efficacy rate. But the real question that I'd like to ask is, what data is there concerning how long one will be protected after getting vaccinated?
So Joe, that's I would say $1 million question. We do not know that answer, like how long the vaccine response lasts. That's number one. And number two, what is the efficacy, which means how effective it is going to be in preventing getting the viral infection in the future. I think those are the studies which will come out as to the longevity, or you would say durability, of the immune response and its correlation with protection. That data is lacking.
Okay, so it's kind of a long-term study in progress at this point.
Yes, I think multiple investigators are going to be looking into immune responses. How long do they last? Is it just antibody mediated, or there's what we call as a cellular response, T cell response to the vaccine as well, which theoretically would lead to a sort of prolonged protection or immunity.
And the understanding currently is once one is fully vaccinated, that I guess essentially you are immune to contracting the virus, but you can still be a carrier. Is that correct?
Well, I would say this. The whole intent of the vaccine is to reduce the risk of developing disease. You can still get, so there's a difference between getting infected and developing disease. Disease is when you're manifesting the end result of an infection. So in the Pfizer and Moderna trials, you've seen that there were patients who got vaccinated. They did develop the disease, but they did not have severe disease. And it was a very small number compared to placebo. So it was very effective in preventing disease or severe disease, or people had mild illness only. And you're right. I'm saying when you do get vaccinated, you can still have the infection. So you are still at risk spreading the virus to others. So the key part is even if you get vaccinated, please wear a mask, hand hygiene, and also physical distancing.
Now, we've also heard reports, obviously, about some people having adverse reactions to these vaccines. And most recently, here in the Southern California area, in fact, in San Diego, I believe, there was discussion about what they suspect is a questionable batch of, again, the Moderna vaccine. I'm assuming we're hearing so much about the Moderna vaccine because it is the one that is most widely being circulated currently. Would that be a fair assessment?
Well, it is more widely being distributed within the community rural areas because it doesn't require the complexity of cold chain requirements of the Pfizer vaccine. So that's one part to that, why you have so much Moderna in the community. The second part to what you alluded to is about the side effect. I think that is still being evaluated. So we just don't know at this point that it is specific to that batch due to whatever reasons. That's hard to tell. I think it's all going to be speculative if I say something.
Well, the reason I mention you were characterizing them as side effects, but some of the media outlets, in fact, many have reported what they're calling or they're terming adverse reactions that required some form of medical intervention. And so I'm wondering if you can tell us a little bit more about those. Obviously, those have all most of them have taken place in older people being given the vaccine, and for obvious reasons, that's one of the few tiers that are currently receiving the vaccine are the healthcare workers, first responders, and those age, I believe it was actually over the age of 70 initially. But again, I'm wondering if you could shed a little light on some of these adverse reactions we're hearing about.
Well, I'm saying if you look at the vaccine trials, definitely these vaccines are associated with side effects, which is basically indicative of your immune response. And some people may have exaggerated immune response, and so common side effects have included fever, injection site pain, or swelling. And there's always a risk for a dysregulated immune response too, and anaphylaxis, as has been the case, regarding the San Diego reports. But again, I would caution in interpreting them, especially if you have that small number of cases, whether, it's large population vaccination which is happening. So I think to get details more scientifically as to what is the root cause here would be helpful rather than, again, giving any speculative answers.
Okay, fair enough. When the vaccine gets to the point of wider distribution, that is when most people will be able to go and seek a vaccination if they so desire. One of the things that we're being told is that even if you have tested positive for the coronavirus, it is still being recommended that you get the vaccine. I'm wondering why that decision has been made when there seems to be a limited supply of the vaccine so far, and the conventional wisdom suggests that once you've had an infection like that, that you would naturally develop some sort of immune response to it.
Well, that is true for the most of the infectious diseases where, examples being measles or mumps or rubella, where there's a natural infection, you may have long-lasting immunity with those. But respiratory viruses, especially things like coronavirus, we have what we call as endemic or human coronaviruses, which have been with us for millennia. I'm saying these are viruses which cause illness like common cold, and people can get infected with coronavirus multiple times in a year. I'm saying with the regular coronavirus. So the immunity is not long lasting. So on that premise, it has been suggested, and knowing the knowledge that the immunity wanes over time for respiratory viruses, it is suggested you get vaccinated.
So, and this has been an ongoing question for some time. with the vaccine, a lot of people are looking at this as the miracle cure. But is it in fact a cure, or will this be a situation where, like the flu, we'll be getting shots at least once a year for basically what amounts to the rest of our lives?
Yeah. So I think we are going to continue to learn as we go along. I give an example of HIV and AIDS that's been around with us for more than 40 years, and there's still evolution of science and management. So this is a new virus, and we're learning every day something new, and that'll continue to be the case. But you're right, I'm saying this is a virus where you may end up requiring vaccination more than once. That is correct. And I don't think that the vaccination alone is going to be the fix this year or the year next. It may reduce the numbers, but at the end of the day, it's the behavior which is going to be really central to beat this virus, to reduce the transmissibility.
Okay. Another interesting observation about the virus and the way it seems to affect or infect people is that it seems to uh, have more of an effect on some groups than others. There have been discussions about comorbidities, things like diabetes. Certainly, age plays a factor in that. There are many different ailments that evidently can lead to a more severe case of the infection. And then there are those that we've heard that present with no more than a runny nose and a sore throat, and a few days later they are better. There has been a lot of speculation about what causes some people to have a more severe case than others, one of which has been suggested to be that blood type may play a factor. I'm wondering if you can tell us a little bit more about that.
Yeah, so there was a paper which came out in Annals of Internal Medicine not too long ago from Canada, which was a population-based study. It is hard to, I'm saying, it showed that the patients who had O group, or there's a what we call as a rhesus group, which was negative patients, rhesus negative, they are less likely to have severe disease. I would still use caution that I think it's not as simple as only one thing, whether the blood group is a thing. I think it is still a sort of post-immune response. There's so much variability in how we respond to different infectious pathogens that we are still learning, and that's going to be the case with coronavirus too. It is quite clear that those patients or individuals who have underlying comorbid conditions like diabetes, obesity, hypertension, including cancer, and those who are undergoing chemotherapy or immunocompromised hosts are more likely to have bad outcomes. So I think we'll be identifying more things as we go along. What could be protective features? What could be, the factors which lead to bad disease?
Moving back into the vaccine itself for a moment, we were discussing earlier the idea that once vaccinated, you, in theory, have a high level of protection from in actually becoming, or yeah, I guess becoming infected with the coronavirus, but that you can still carry the virus and spread it to other people. With that in mind, children, for the most part, seem to have a much lower rate of severe reaction, but definitely can still transmit the virus to others. So, what about testing of the vaccines with children?
There are clinical trials which are ongoing in children who are below the age of 16 years and above the age of 6. So those clinical trials are ongoing.
So,
So, yeah,
there isn't a specific timeline at this point for beginning vaccinations on younger children.
I am not aware of it at this point.
Okay.
You could get vaccinated with one of the vaccines above the age of 16 at this time. Yeah.
And I guess the takeaway from all of that is even if you have been vaccinated, it is still very, very important to practice most of the recommendations that we have been given all along for trying to stem the spread of this, which is wearing a face mask and maintaining social distancing, among other things. Is that correct?
That is absolutely correct. That is, I'm saying being vaccinated protects you, but we have to realize our actions can put other people's life at risk. So that is really important to continue to practice while we see all these big numbers in the community.
Well, we have just a moment or so left. I'm wondering if you could give us your long-term prognosis for our situation with the COVID virus.
Well, uh, being a physician, we are asked to prognosticate. This is more of a epidemiological question, which is hard to prognosticate because it depends heavily upon human behavior and what the virus does in terms of mutation, as we discussed earlier. But I think if we all work in tandem with each other and be responsible citizens, get vaccinated, and reduce the likelihood of acquiring or transmitting to others, especially after the transmission which we've been seeing recently is within families, close friends, um, because there's an increased risk of exposure by being in constant touch with each other. It is important to observe the basic tenets. If we observe those basic tenets of avoidance of acquiring the infection or transmitting it along with vaccination, that is a key part which can really quell the pandemic quickly if people do all that.
Dr. Sanjit Dadwal, Chief of Infectious Diseases at City of Hope, thank you so much for joining us today and for sharing your considerable medical knowledge and insights on this. We really appreciate it. And I certainly hope that you and your staff are able to stay safe and continue to do all the great work that you've been doing.
And thank you, Joe, for doing what you're doing. It's really helpful to pass on the message to the community regarding vaccination and staying protected. Thank you for having me.
Thank you. Joining me this evening, Dr. Aaron Lewis, a surgical oncologist with City of Hope. Dr. Lewis, how are you today?
I'm doing great. How are you, Joe?
Wonderful. Thank you so much for taking time out of your busy schedule to join us. Dr. Lewis, the virus obviously has created numerous problems in just about every sector of daily life. How has it affected surgery?
At the City of Hope, our main focus is on cancer and providing high quality cancer care at the forefront of medical knowledge. And this has allowed us to continue to perform surgeries through the pandemic. And we've really been on the forefront of surgical technology and techniques for many, many years. As part of this, we perform minimally invasive surgeries. We perform robotic surgeries. And this has allowed us to continue to provide high quality care with quicker recovery times, shorter length of stays, that also decreases the risk of potentially spreading or catching the virus while getting treatment.
What about some of the techniques such as computer-assisted surgeries or now we're hearing about the term virtual surgery? Can you tell us a little bit about those things?
Sure. Computer-assisted, is really part of robotic surgery. And so when I'm sitting on the robot, I'm actually sitting at a console away from the patient. This gives me the advantage of minimizing that patient to doctor contact and providing space. In terms of virtual, that's really cutting edge, and we're not quite there yet.
Okay, but that's something that you can see coming on the horizon.
In the future, I think the technology has to catch up to the grand ideas in our head.
Okay, I can certainly understand that. What about, and what do you say to patients with fears? Have you seen a drop in patients because of the virus, people afraid to go to the hospital?
Of course, we all have been affected by the virus, and for sure, there have been patients who unfortunately have presented much later than they would normally have presented, and unfortunately, that can affect the outcome, particularly in cancer care and in cancer treatment. My advice is that you need to continue to be evaluated. If you have symptoms, if you have concerns, you should be evaluated by your doctor. Because, like I said earlier, we are continuing with cancer care, whether that's surgery, whether that's clinical trials, medical oncology or radiation oncology. We are continuing with treatment, and so it's important to be evaluated, even if there is that fear of potentially catching the virus during treatment.
Earlier on in the onset of the pandemic, we heard about the closures, obviously, of lots of businesses and even the stopping of what were termed non-essential medical treatments and surgeries. What is the standpoint of that situation now? How has COVID affected you directly? Or is it largely business as usual at this point, or are there certain considerations and factors that must be weighed before a surgery is committed to at this time?
Yes, at this point, there is a state mandated hold on elective surgery. The definition of elective surgery has been spelled out, and we do have guidelines for continuing with surgeries that might be considered critical. At the City of Hope, every patient is evaluated by their physician, their surgeon, and a team of leaders to determine whether that surgery should continue. And for the large part, surgery does continue at the City of Hope because our mission is to take care of cancer patients who need to continue to get treatment.
Are there other concerns, other effects of COVID-19 on cancer patients? I mean, obviously we hear about the comorbidities and those are of great concern when it comes to the pandemic. But if someone has cancer and then it contracts the COVID-19 virus, are we at this point aware of what potential side effects and ramifications there may be from that?
Specifically for cancer patients, there have been several studies that have come out over the last year, and really they're mixed in terms of how COVID-19 specifically affects cancer patients. What we do know is that patients who hold back on treatment can potentially present or have the consequences of delaying their care. And for that reason, it is important to continue to get treatment for cancer, whether that's surgery, chemotherapy, radiation, or whatever treatment it is. It's important to continue to get that treatment because of the potential consequences of delaying care.
How important is continuing to screen for cancers in the face of this pandemic?
It's very important to understand that we need to continue care for cancer patients, even in the setting of those that are undiagnosed. There is a specific group of patients who should, at very least, should continue with their appointments and at very least space out their appointments at a minimum rate. And that would be patients who are high risk for cancer, patients who have family members with cancer or who have known genetic mutations. These patients should still continue their strict surveillance with screenings. On top of that, patients should be aware of symptoms that would warrant further workup. Specifically for colon cancer, that would be change in bowel habits. That would be detection of blood within the stool or unexpected change in weight. For breast cancer, that would be a new lump or pain within the breast. For skin cancer, that's a change in the size of a lesion or the change in the quality of a skin lesion. And for lung cancer, that would be a new cough, fatigue, actually symptoms very similar to what you would experience in COVID-19.
Dr. Lewis, can you tell us about the precautions that are taken at the City of Hope whenever a patient comes in, especially one that's coming in considering surgery?
First and foremost, any patient that undergoes a procedure or a test is going to be tested for COVID. On top of that, all of the staff has been is regularly tested, and we follow the guidelines, the CDC guidelines, in terms of minimizing the risk of exposure. All employees wear protective equipment. Patients, when they come in, wear masks. We have a no visitor policy such that it minimizes how many people are in the clinic at any given time. On top of that, we have spaced out the clinics both by also expanding our telehealth program so that the minimum number of patients are in a clinic at any given time.
What precautions would you take or do you take in the event that you have a patient that has tested positive for COVID-19?
That at that point, we have to decide how urgent that surgery is. In some cases, that may be postponing the surgery for a couple weeks until the patient has recovered. If a patient has a life-threatening condition and needs the surgery regardless of whether they're positive for COVID-19, then extra precautions are taken within the operating room in terms of the protective equipment that the staff would wear, the cleaning of the room and the instruments, and so that's the approach that we would take for somebody that is COVID positive.
And obviously, the same recommendations apply to persons who are afflicted with cancers as with the rest of us. The importance of maintaining social distancing, wearing masks, and so on. That's all equally important. Is that correct?
Equally, and maybe even more important, because staying on top of care is so important for cancer. Staying on schedule with treatment, and any delay in treatment or complications, side effects, or whatever that would delay that treatment may affect the outcomes. And so it's all the more important to potentially decrease the risk. What I can say is at the City of Hope, we have taken measures to decrease those exposures. Patients have the option of telehealth visits versus inpatient appointments. And when patients do come in, we space those appointments out. We space out the patients in the waiting rooms, in the infusion centers, in the clinics, such that the risk of exposure is minimized.
Certainly, as a result of the pandemic, we've heard a great deal of discussion about the factors such as comorbidities and how that can negatively affect the outcome of a COVID infection. Obviously, having such a serious affliction as a cancer would be of great concern. What are the things that one can do? Are there things that one can do, and certainly not with all cancers, but are there things that we can do to help reduce our risks for cancers? Obviously, something that's perhaps more important now than ever in the face of the pandemic.
Well, there's multiple factors that can increase your risk of cancer. There's obviously genetics, although that only accounts for about 10% of cancers. Outside of that, a large part of your risk of cancer is your risk factors. For example, in lung cancer, that's smoking, and in fact, smoking increases your risk of many cancers. For colon cancer, it's your diet, how much red meat you eat, and so in whether it's during a pandemic or whether it's during normal period of time, yes, it is important. You can decrease your risk of cancer by living a healthy life.
What advice does the City of Hope have for patients that are considering or requiring surgeries?
So it's very important to continue to be evaluated as you are able to come in and seek out advice on whether to proceed with an operation, or if an operation could be successfully delayed. That is really determined at the point of evaluation.
And to those who fear coming in simply because of COVID, do you have any advice there?
Sure. At the City of Hope, we have other ways of evaluating patients. As I had mentioned before, we have a telehealth program where we are able to evaluate patients, whether that's a new patient or a patient that is well known to us. We're able to offer opinions with patients in the comfort of their own home.
Thank you so much for your time and your expertise today. We certainly do appreciate your speaking with us and sharing with us your knowledge. And we thank you for continuing to do all the work that you do to keep everyone healthy.
Well, thank you very much. Glad to be here.
Joining me now is Dr. John Zaya, the director for the Center of Gene Therapy at City of Hope. Good evening, doctor, and thank you for joining us. How are you tonight?
Fine, thank you. Thank you for having me.
It's a pleasure, and we do appreciate your taking time out of your busy schedule to speak with us tonight. I guess we'll get right down to the point. What is the City of Hope doing in the fight against infectious diseases? And obviously the one on everybody's mind is COVID-19.
So we have a vaccine that we have made here. We call it the City of Hope vaccine. It's in a clinical trial right now. People who are interested can email us at covidvaccine@coh.org. And what it is a new platform. People wonder why do we have another vaccine? Well, basically vaccines are always improved upon, usually after the first one is made. The best example is the shingles vaccine. We're no longer using very much of the first vaccine, but we have a much better one now. And that's true for polio and all the other vaccines. So we have now made a vaccine that's in a different background or a different platform. We used one that's very commonly used. It's been around for decades. It was from the original Vaccinia programs. We call it MVA, stands for modified vaccinia. And we put into it 2 proteins from the virus rather than one. Instead of just the spike protein, we have the spike protein plus an internal protein. And we think the immunity will be much better and much more long-lasting, although that remains to be shown. But we have now this first trial, and we're enrolling patients right now at City of Hope, and especially for people who can't get to the standard vaccines, the Pfizer vaccines and the Moderna vaccines, because they're in the back of the line. This is an opportunity for them to get a vaccine that we think is a pretty good vaccine that immunizes animals very well, and we would welcome anyone's interest.
Well, of course, the first question that comes to my mind is this also a 2-shot vaccine, or is this a single dose?
That's a good question. Of course, the goal is to have a 1 shot that lasts for several years. And that would be ideal. So we actually are testing both 1 shot and 2 shots with this vaccine. We don't know which will work. 1 shot certainly does induce some nice antibodies in our tests so far, but not in humans, only in our animal studies. So we're hoping that 1 shot will work, but that remains to be answered, and that's the question of the study that we're doing now, is to determine whether we can do it with 1 shot or 2 shots.
Okay. And you did mention that the ultimate goal would be to have a vaccine that provides a good level of protection for several years. What is the current estimate of how long the protection would last on one of these?
That's a really good question. Nobody knows the answer to that question. And you listen to Anthony Fauci fielding that kind of a question, and it remains to be determined. Remember, the time period at which we observed immunity after the Pfizer and the Moderna vaccines is only a matter of a couple months. And at that point, they already had so much evidence that there was protection that it was approved. But no one has looked at 6 months and 12 months to say, are these people still protected? The real question is, will our first line physicians and nurses, firemen, policemen, will they be protected in 6 to 12 months? And nobody knows the answer to that question.
Well, if I can wander into perhaps what amounts to more like speculation, certainly there have been parallels drawn between the COVID virus and a very, very strong flu. I don't know how accurate that actually is, but it seems that the flu vaccines are generally only good for about a year, and this is probably largely due to the fact that the flu virus mutates within that period of time. But we have seen that the COVID virus seems to be mutating even more rapidly. So with these new vaccines, how can they be adapted to these variants of the COVID virus?
Well, one way to do it is to put 2 proteins into the vaccine. And so that's exactly what we've done. Because it's very hard relatively easy for the virus to escape, as we say, when it only has to mutate around one antibody, let's say, that's recognizing one protein in the virus. But to mutate around 2, it's very difficult to do. And so we're hoping that by having a vaccine with 2 proteins in it, you would prevent that resistance or that escape from immunity.
Okay. All right. So the likelihood then that if a new variant is discovered and turns out to be resistant to the current vaccines, is it possible to quickly adapt these vaccines to these new variations?
Well, the word quickly is a tough word to define in this setting. It was very fast to make these vaccines, now relatively speaking, but it was still a good 9 to 10 months. How quickly could we turn it around if there is new spike proteins that have to be put into the vaccine? I think it may well take a good 6 to 9 months to do that.
Okay. That's always a bit concerning, of course, but medical science works at the speed of medical science. There are so many different questions that I'd love to ask. One of which is, you refer to the vaccine as a new vaccine, and obviously it's new because the coronavirus is something we've not addressed before, but it differs in other ways from conventional vaccines as well. Is that correct?
If you're referring to our vaccine or the Pfizer?
Well, it seems that most of the vaccines that are being brought for use against this COVID virus are different from conventional vaccines. That's
correct. So the Pfizer and the Moderna really are unconventional in that they are RNA vaccines. And that was actually our rationale was, let's go to a vaccine that's been used for decades. And that's how we got into the vaccinia area. And vaccinia is the kind of vaccine that allows you to add, and again, using genetic methods. And since we were a gene therapy center, our investigators put into the vaccinia the 2 new proteins from COVID. And so then when you inject the vaccinia into a person's arm, the body thinks it's seen COVID because it's seen the proteins from COVID, and it makes immunity to that. So we're using a conventional platform, one that's been used for decades. And we know that with vaccinia, we had immunity that lasted for years. So we're really hoping that this will be a way to produce immunity that will be very long lasting. In addition, we stimulate the T lymphocytes, we call them. That is, you have cellular immunity and you have antibody immunity. So we're stimulating both the antibody and the cellular elements of your immune system. And it's the T cells that last for years in terms of immunity. Like measles. When you give a measles vaccine, it lasts for your lifetime. It's because the T cell immunity lasts for that long.
Well, the reports that we've heard from antiviruses such as the Moderna suggest that they have a 95% efficacy rate. And how does that compare to your vaccine?
Well, we have no idea. Our vaccine is still in the phase 1. And by phase 1, we mean we're looking for the optimal dose that is both safe and produces really good immunity. So in the next few months, we'll have an answer to that question. probably around April, we will know. And at that point, we can expand our trials to answer that question you just raised. Is it really effective at protecting people?
One of the, I don't want to call it the darker sides. That's probably overstating it. But one of the concerns that has come out of some of the new vaccines have been that there seem to be a certain percentage of the population that are suffering adverse, sometimes severe adverse reactions. Since your vaccine is taking a more conventional approach, what are the side effects or possible ill effects of taking such a vaccine?
Again, we're finding that out right now, but based on there's been hundreds of thousands of people who currently get modified vaccinia for some other reason. And it's unusual, but it's approved for example, cowpox. So dairy workers who are exposed to a lot of potential for having cowpox get this vaccine. And it's very safe in that population. That's all we can say. We don't know yet the spectrum of side effects, but we expect it'll be the standard flu shot vaccine side effects. Now you have a little sore arm, you may have a low-grade fever, you may have some chills the next day, you may feel a little bit tired, but we don't expect anything worse than that.
Okay, well, a moment ago you were discussing gene therapy, and I'm wondering if you could tell us a little bit more about the process of the study of genes and gene therapy.
So, of course, you remember that the genetic code is the code by which your body and all the cells in your body do their day-to-day processes, how to make a certain kind of a protein, whether it's the enzymes in the saliva in your mouth or in your stomach, or whether it's your skin cells that turn dark colors if you expose them to the sun because they make melanin. All of those proteins are encoded by genes, and the genes are your DNA. So you can take DNA, it's a chemical, and you can process it, clip out certain sections of it, put in new sections, and now you'll have a new gene. So when you apply that to treatment of disease, it's called gene therapy. When you do it for a vaccine, it's been done by Moderna and by Pfizer and by us and others, is to make a COVID protein present in a let's say a syringe that could then be used to make a vaccine. So gene therapy is used primarily now for very rare diseases. People, the boy in the bubble is the classical disease where you can correct the immune system by giving that missing enzyme that these kids have by doing it genetically. Sickle cell anemia is another example that's been very successful recently, in which you can give a hemoglobin that corrects the problem of the sickle cell hemoglobin. So that's the basic application process for gene therapy.
I would like to ask this one question. There are certainly some more questions I want to ask about gene therapy and the COVID virus, but one of the questions that I would like to ask is it possible at some point that we could come up with not only a temporary vaccine, but a permanent cure for COVID, where we're not looking at repeated shots over the years?
Right. Well, one thing that we really need is a pill that blocks the virus. We have it for flu. Tamiflu was a very successful oral agent that you could take. So when a physician saw a patient that had a bad upper respiratory infection, it might be the flu, he could test right away in his office. He could give Tamiflu. And then he could encourage the person to get a flu vaccine also. It's the same thing is true here. If we had an oral agent, and there are, people are working just as hard in that area as they've been working in vaccines. So the question is, can we make an oral agent that blocks coronavirus? Well, of course we can. There is already remdesivir, which we use, but it's an intravenous drug. It's only used for people who are quite sick and they have to be in the hospital. We need something that's oral that your doctor can prescribe for you, and you can take as soon as you get a symptom. You get the symptom, you get tested, you're positive, and then you start taking, let's say, a 10-day course of these pills. That is what's really needed and would greatly bring this whole process to a conclusion, I think, this whole pandemic.
Of course, in the interim, we continue to see the rate of infections climbing, and largely that's been attributed to a lack of social distancing, a lack of, I guess, respecting the conventional rules of avoiding the continued spread of a pandemic. There has been lots and lots of discussion about a vaccine, but what research is being done for treatments for those who already are afflicted with the virus? We've certainly all seen the images in the media of hospital patients that are on ventilators. We hear about people passing quite frequently, unfortunately. So what further research is being done on ways to treat already infected and severely ill patients?
Well, of course, that's where a lot of activity is going on right now. I think every major center has their approach to this. So you have to think about why you get sick. One of the reasons you get sick, of course, is that your immune system is triggered by this virus to act. And it acts by suppressing the virus using its whole armamentarium of weapons. And it has what we call interferon. It has other things which are we call cytokines. And all of those prep the cells to become warriors, let's say, in attacking the virus. At the same time, we have a system in our immune system to turn it off, because if these warriors became out of control, they're going to tear up the whole system and there'll be a lot of bystander effect. So you have the ability to take immunosuppressive medicines and try to turn off the immune response, because many people who are getting very sick and are heading for the ICU have in their body this activity going on, this hyper immune response to the virus. So we have a number of agents that we can give the patients to turn it off. They're immunomodulatory agents, and steroids are one of those. But there are other medications as well that are being used. So that's the one area that I think there's a major amount of.
Well, I'm certainly not a medical expert, but what you're describing sounds a little bit like the anaphylactic reactions that some patients have had to the vaccines that have been administered. Is that a fair assessment?
Well, yeah, anaphylaxis is kind of the first immediate response of this army, let's say. But it's triggered. That's the thermonuclear button that got pushed, and so we can turn it off. Though I mean, there's a nice. I mean, EpiPens work very well for anaphylaxis, and it's and that goes away. It's almost just a humoral type of. We call it humoral because it's all fluid activities that signals that occur that trigger that process. But when your cellular elements invade your lungs and they're causing pneumonia, that's a little more difficult to turn off.
Okay. Well, thank you for clearing that up. I certainly do appreciate that. I find that educational myself. I would like to ask, and again, I understand that your hospital is directly involved in researching another new vaccine, but can you speak to the overall safety of all of the vaccines that are on the market? Certainly there's a large percentage of people that are hesitant to take this vaccine because they hear that they're new, and there are reports that some people are having adverse reactions. Would you speak a little bit on the overall safety of these vaccines?
Right. I mean, overall, they're incredibly safe. I think that taking the risk of COVID is much more dangerous than risking having the shot of vaccine. There are a rare person that has a severe reaction, but that's true for anything. Flu vaccine, if you read the small print on the information page for flu vaccine, there's some really bad things that can happen after a flu vaccine. Anaphylaxis occurs occasionally. We heard that surprise that Bell's palsy, that's a paralysis of the side of your mouth, of your face, happened in 1 in 5,000 people who got both the Pfizer and the Moderna vaccines. No one would ever have predicted that. So some people are predisposed to have a reaction to the vaccine that somehow cross-reacts to some some nerve in their body, some nervous tissue. We don't know why that happens, but there's always that small risk, but it's an incredibly small risk compared to the risk of getting COVID and ending up in the hospital.
And again, I'd like to ask that certainly even after one is vaccinated, it's definitely still important to maintain social distance, continue to wear masks, all of the conventions that we've been told since the onset of the pandemic. Is that correct?
That's correct. We still don't know for sure if you could get reinfected and not get sick. What we observe mostly is that people are not getting sick after they get the vaccine. But can they actually spread it? And that's the unknown. Could you pick up the virus and then spread it without getting sick yourself? We don't believe that that's happening. There's some pretty good data from the Moderna study that does not happen. With the Pfizer vaccine, it's likely that it doesn't happen either, although they did not look at that specific question in that study. But I think that it's pretty good guess, let's call it, that if your body is suppressing the virus so you can't get sick, it's also altering the virus in some way that you can no longer spread it as well. You just don't, it just doesn't come out as you're talking or interacting with other people.
Well, that certainly sounds like wonderful news. Hopefully that turns out to be the case, and we'll certainly be looking forward to the introduction to market of your new vaccine along with all the others, because obviously the more we can get to throw at this, the better we are, and hopefully the quicker it will go away and we can get back to normal.
Well, it's going to take a while for us too, because we're just in the beginning stages, but we encourage people who want a vaccine and they're tired of waiting to email us at covidvaccine@coh.org. I'd be happy to see you and bring you in for an evaluation.
All right. Thank you very, very much, Dr. Zay. We really appreciate your joining us this afternoon and taking time out of your busy schedule. Again, the information that you provided is very, very helpful, and we certainly do appreciate your taking time to share it with us.
Good. Thank you very much, Joe.
I'd like to thank Drs. Sanjit Dadwal, Aaron Lewis, and John Zaya for joining me this evening. To those at home, if there are topics you would like to see addressed in our discussion, you can email them to us at arroyolive@pasadenamedia.org, and we may include them in a future broadcast. Until next time, this has been Arroyo Live. I'm Joe Carbonetta. Thank you for watching, and good night. City of Hope offers a clinical network consisting of more than 30 locations across Los Angeles, San Bernardino, Riverside, and Orange counties, allowing patients throughout the greater Los Angeles area access to City of Hope's renowned cancer research expertise, physicians, treatments, and clinical trials.